I came to Mercatus about 2.5 years ago, specifically to take a somewhat contrarian view on healthcare policy. I had come out of 6 years in the ACA debates, whatever, and I came to Mercatus with the argument that since World War II, the entire debate about health care in America has been about coverage, about insurance, about how many people have a plastic card in the pocket. And my argument coming to Mercatus was that I couldn't begin to tell them how dull and uninteresting and unproductive the debate over coverage was. To put it simply, we had a problematic system before the ACA. The ACA created a problematic system. The various repeal and replace proposals are problematic. So I wanted to take a very different tack in healthcare policy, which was to look not so much at coverage and insurance, but to look at the actual care, how we deliver health care in America, and what it does to our health. And so the question that I ask is based around this. Why, if you look back over the last 25 years, why has innovation been so incredible in the sphere of information technology, whereas innovation in healthcare itself has crawled along painfully slow? And a related question, which is how can we make healthcare as innovative in the next 25 years as IT was in the last 25? And part of the answer that I'll talk about today is to study some remarkable legislation that happened right here. So let's look at IT first. I have here an iPad that cost about $600 when I bought it 2 years ago. Theoretically, when I was a kid, the computing power in that iPad, which you couldn't have bought, but if you added up what computing power cost then, that one iPad would have cost $100 trillion, which is about 5 or 6 times the size of the entire US economy today. Of course, you couldn't have bought it. Wouldn't have been much to do with it either. Let's look at this, another of my toys here, the cell phone. 25 years ago, you know, for this crowd, when you were either very young or maybe not even young yet, I knew one person who owned a cell phone. It was a big clunky thing in a bag, and it was kind of cumbersome to carry around, and there weren't that many people to call with other ones. Today, 25 years later, thanks in part to legislation that happened here, there are 7 billion of these on Earth, about one for every human being on Earth, which, to put that into perspective, there are more cell phones on Earth today than there are toilets or toothbrushes. To put it in terms that are familiar to healthcare but not to IT, we went in 25 years, less than a generation, from a point where a cell phone was a toy of very rich people. The woman I knew with a cell phone had 7 houses. We went from that, where this was something that a very wealthy person would own as a status symbol, to universal coverage. We achieved in 25 years universal coverage of what had been a very expensive item in your lifetime. It didn't take mandates, didn't take gigantic subsidies, it didn't take commands, and it went worldwide. So I used to travel in sub-Saharan Africa in the 1980s. It was virtually impossible for me to get a telephone call home to the woman who's now my wife. About once a week, I could get a call for 3 or 4 minutes if I was lucky. Today, little kids in impoverished villages in the third world have these things in their pockets. This particular phone is more powerful than any computer that the Central Intelligence Agency would have owned at that time. It's an astounding change. Now, a tech-savvy person 25 years ago would have found these things impossible to describe. If I went back in my DeLorean to 1990, and I talked to computer people back then, and I said, You know, in 25 years, I'm going to own a little thing like this. It fits inside a manila envelope. It will know at all times exactly where on earth I'm standing. All I'll have to do is push a button and say with my voice, how do I get to Alexandria, Virginia? And it will give me directions, it will follow me, it will track me. It'll also be my camera. It'll also allow me to talk video with those kids in African villages that I used to travel. It'll be a word processor. It'll have information on every movie. It'll have all of that. And it will cost $600, and all these extras, all these add-ons, the apps, will be free. First of all, no one in 1990 could have even conceived of this device. And if you sat them down for a few hours and explained it, they would have said, well, how much is this thing going to cost? And you said, $600, and all the other stuff's free. It would not have been at all believable. Now, I teach at a couple of medical centers. My students, I teach at VCU and UVA now. My students are, by and large, doctors, nurses. Some of them are med school professors, chairs of med school departments. And I ask them, I throw out a little challenge. I said, this would have been impossible to believe 25 years ago. If you were to travel back 25 years and come to the medical center here, what could you tell them that we're doing in 2016 that they just absolutely couldn't believe? And there's almost nothing they can name. They'll say, well, we have a hepatitis C vaccine now, that's nice. So, well, if you would have gone back 25 years, they would have said, wow, that's going to be great. Nice to have another vaccine. They wouldn't have found it difficult to believe. When the students struggle for something, invariably what they come up with is something in the realm of IT. That, okay, you've got a jawbone that's recording your vitals, your heartbeat, your whatever, and it's sending it remotely to a computer, and it's tabulating. That's the amazing stuff in it. And I'll tell you a few other things. And one of the fascinating things about it is I obviously love my toys, and I talk about the technological changes coming to healthcare. And by and large, when I teach it to medical school professors and others, they've never heard of most of what I'm talking about. They are unaware of, and I'll talk about it later, three-dimensional printed prosthetic hand that reduced the cost of giving a child a workable hand by about 99.9% in the last 3 years. These are the things that are exciting, and these are the things that are going to change the dynamics of healthcare and the financing of it in this building. So let's see, what else? So here's the problem. Here's what frustrates me in having the insurance discussion. So I don't get real bent out of shape over the ACA. I don't think, frankly, that it changed very much. And if someone comes in and gets to single payer, that's not going to change very much. And if the conservatives get a repeal and replace, I don't actually think that's going to change very much. The problem is, when you're talking about insurance, you're talking about distribution or redistribution. Let's put it this way. Before the ACA, there was a certain number of doctors. There was a certain number of nurses. There were hospitals. There were a number of beds in those hospitals. There were laboratories. There were CAT scan machines. There were MRI machines. There were all the infrastructure of healthcare. And all of those were really busy. Doctors were busy from morning till night. So were the nurses, so were the others. So what changed in the ACA? Did we add a lot of doctors? No. Did we add a lot of nurses? No. Did we add hospitals, hospital beds? None of the resource base of healthcare substantially changed with the ACA. Now, we promised a group of people you can have more access to doctors. Well, since the doctors were busy from morning to night to begin with, if you were getting more doctor care, that meant you were going to have a little bit less. So what we were doing was moving things around. And I can make precisely the same argument with all the repeal and replace proposals that are out there on circulating around the Hill. They're all arguments about how do we take the stuff we've already got and shift it around. Because similarly, very little in the ACA or in any of these other proposals changes fundamentally the way we deliver health care to human beings, which is what matters, or how much health they get out of that. Now, this is going to change. This is already beginning to change rapidly, and it presents enormous opportunities. We are in a period now when there's a convergence of technologies, astounding technologies. It is possible now, for instance, I could download a little app on here called AliveCore. AliveCore would allow me to, and I'm not sure if it's a little peripheral or if the camera does it, it will allow my telephone to do an electrocardiogram and tell me whether I'm in the middle of a heart attack or not, or if I just have indigestion. I have, let me look at my time. This person keeps me busy with my clock. And I'm doing good. About a month ago, I had a different sinus infection. My doctor was away, so I went through an app on here, called a California company, and in 2 minutes, I had a doctor in New York State examining me in Alexandria, Virginia, looking down my throat. And in about 10 minutes, there were prescriptions waiting around the corner for me at CVS. Telemedicine is expanding. The possibilities of it are expanding greatly. This is a toy that I just got. This is a stethoscope that hooks into it. So if I want, I can plug this into here. I can breathe, and you can hear I've got a bit of congestion. This can tell me whether I have bronchitis or pneumonia. And if I want to call the doctor in New York State or in California or wherever, they can take the same readings and tell without my ever having left my house. This is a thermometer. It also allows them to look down my throat, into my ears. There's another peripheral I don't have here. You can stick into your ear, and it will tell you whether you have an ear infection without leaving your house. My son and his roommate just used this to get some medications, and the roommate said, this was 8 o'clock at night, in 10 minutes both of them had prescriptions waiting, and he said, I now understand how my grandparents felt the first time I showed them a computer. 3D printing. This was invented not by medical professionals, but by a carpenter in South Africa who cut his fingers off in a table saw accident. He contacted a puppet maker in Washington State. They collaborated and built these, and a professor at Rochester Institute of Technology built a Google Plus site that spread thousands of these around the world. 3 years ago, if you had a child without a hand, the child was going to wait till he was 18 years old to get a prosthetic because the cheapest were $5,000. And the child, you couldn't keep buying one every few months as the child grew. So you said, sorry, kid, you'll wait 18 years and you'll have a hand. These cost about $20. They're given away. So a year and a half ago, I wrote a piece, a monograph, a little book called Fortress and Frontier in American Healthcare. It's on our website. You can download a PDF, or you can go to Amazon and get it in Kindle form. And it talks about these changes. And what I argue in that is that the real distinction in healthcare in America is not between the left and the right, or the Democrats and the Republicans. Rather, it's between two visions that I call the fortress and the frontier. And the explanation of the difference here is that in the last 25 years and longer, healthcare has been locked inside of a fortress. IT, because of congressional action around 1990, was sent out onto the frontier where it could explode, where all sorts of people, where Steve Jobs in his garage could challenge IBM in its skyscrapers. And that option remains open for healthcare now if we turn our attention to that and stop focusing entirely on insurance cards. So what's the difference in the fortress and the frontier? The fortress is an attitude, a worldview that says, the purpose of public policy is to imagine every terrible thing that could possibly happen in the course of healthcare and to throw all of your resources at preventing those bad things from happening. Keep everybody safe in all circumstances, which, by the way, doesn't work. And secondly, the second purpose of public policy is to guarantee essentially a lifetime income for those who are insiders, for those who, doctors, hospitals, So we build in all sorts of subsidies, protections from outsiders. With the exception of a carpenter and a puppet maker who could do this, we build high walls that prevent geniuses in unknown places from bringing their wisdom to healthcare and changing things in ways that no one ever imagined before. IT was that way until 25 years ago, when remarkably, and I think it is the single most interesting story in modern political science, and it's unwritten. If you're working on a PhD, here's your dissertation. Around 1990-91, Congress passed and the president signed legislation that unlocked the internet and unlocked various aspects of telecommunications to the world. Prior to 1990, the internet was a closed world with very limited capacity. MIT had, it's in my study, MIT had this thing warning, you must never use the internet for private communications or any business endeavors. The legislation in 1990 unlocked that and many other things. What happened then? Immediately, the world began to expand the capabilities of the internet. We developed all of these devices, these apps. Companies emerged, spent fortunes, invested their lives, and then other guys in garages came and wiped them out. In 1999, I think it was, Google was the 28th search engine introduced that year. Who were the other 27 before? I don't have any idea, and probably no one else on earth does at this point because they went away. Innovation is an accidental process, whereas in healthcare we've tried to make innovation a pre-planned, very regimented process. And that's what has got to change, and that, by the way, it is what is changing around the world. And our choice is whether to be in the lead or to be following. And I'm watching the time, so no problem. And people frequently will interject at that point, yeah, but healthcare and IT are different. Healthcare is your life, it's your safety, it's your health. This is just a machine that sits on this desk. But I will argue that someone in 1990 could correctly have said, this is the most dangerous invention in the history of mankind. With a couple of these, some guys can fly airplanes into skyscrapers. They couldn't do it without the coordination of cell phones. These could detonate IEDs, killing soldiers in Iraq. With these devices, you can steal empty people's bank accounts. You can destroy reputations. You can ruin a person's public image to the point that they commit suicide with cyberbullying. These are extraordinarily dangerous devices. What Congress decided remarkably around 1990 was, we understand the risks, we understand the dangers. People who develop these will take risks. People who use them will take risks. And what we're going to do is let them do that. And as we go along, when the problems appear, we will fix them as they go, which is what we do. Which, of course, right now we've got a big news item this week with the iPhone, with the terrorists in San Bernardino. It wasn't something where we said 25 years ago, let's just not have a cell phone. It's, here's a serious problem. We're going to deal with it through the laws that are already on the books, tort laws, criminal statutes, etc. And the fact that Congress did that remarkably changed the world. It brought these cell phones to the kids in sub-Saharan Africa. And the interesting thing, the fascinating thing is it cannot be portrayed in any way as a victory for the left, for the right, for the Democrats, for the Republicans. It was a bipartisan joint deal. It was a decision to take IT out of the fortress and put it in the frontier. And again, those possibilities are there in healthcare. And I say possibilities, probabilities, certainties. It's already happening elsewhere in the world. The best cardiology hospitals in the world right now are in India, a system called the Narayana, which has just built a beautiful hospital just outside the US. So if you want, you can fly and get your bypass or your transplant just an hour out of Miami for far less money than you'd spend here, and probably a better chance of coming out alive in the end. So what should we be looking at? Well, in healthcare policy, I think we ought to be looking at things that were nowhere to be found in the ACA debate. They're nowhere to be found in the repeal and replace debate. They're things that we have spent so much time obsessing over insurance cards and coverage that we've missed the big stories. So I like to say there are 5, maybe I'll change the number sometime, but for now it's 5 big stories that we could be focusing on. One is the way we approve new drugs and devices. So the FDA, a noble institution that was founded or at least its predecessors were in 1906, just put it in perspective, right after the first airplane flew. It's an old institution. It always had a problem that was identified in the mid-20th century, at least by Milton Friedman and others, who noted if you're at the FDA and you release a drug that kills 10 people, you're going to end up in this building with bright lights facing you and angry congressmen and senators staring you down demanding to know, why did you release this dangerous thing? But if you sit on a drug for 10 years that could have saved 50,000 lives a year, there is no penalty to pay. There's a terrible asymmetry. It doesn't have to be that way. The European Union actually has a much better approval system than we do that gets things out faster and safely. We can talk about it later if you want. But the fact is, these things are happening, and the FDA, whether you like the current system or not, it is going to change because the nature of medical technology is changing. In the mid-20th century, early 20th century, developing a drug or device meant big machinery, big factories, lots of big financial transactions, a lot of money. It was easy to track. Now you have some of the most significant achievements developed by people who are building an app on a cell phone. A father 2 years ago built an app to monitor his daughter's blood sugar levels by plugging it into her insulin pump. These are not things that can be monitored and regulated in the way that we regulated a 6-ton MRI machine in the 20th century. So our decision is not whether to change, but how we're going to change to assure safety and efficacy. So the FDA is one big problem that needs some work. Second is the Medicare pricing formula. Again, I worked in third world in international finance in the 1980s in New York. And without any exaggeration or irony, I can say, analytically, the way we price things through Medicare is the same way the Soviet Union priced everything. Administered prices divorced from any economic realities. And unless you fix that, you don't fix much of anything because it distorts what we buy, how we buy it, what, will Medicare pay for you using telemed? Well, if it doesn't, you're going to impede telemed. The third big leg of this is hospitals. We have federal and state legislation that creates monopolies. People tend to love hospitals. They're the big employer in most towns. They're much beloved institutions, but in many ways they're obstructive. We have certificate of need laws at the state level that prevent lean, mean, like that Indian group from forming new technologically advanced hospitals that can do a better job. We protect the old insiders, and there's a lot of federal legislation that prevents specialty hospitals from challenging general hospitals. We have a whole panoply of state regulations, but they are connected to federal law. So state licensure of physicians creates obstacles to doctors moving where they're needed and wanted. Scope of practice limits what nurse practitioners can do in some states. Telemedicine. I love pointing out when I speak to right-of-center legislative groups that right-of-center states are the most obstructive in the nation as far as allowing the use of the telemedicine that got me my meds a month ago. I recently tweeted out that Texas needs to learn from more free market-oriented outfits like the VA and New York State as far as telemedicine, because that's where the advances are. But again, there's a federal role in these as well. And fifth, is the design of medical schools. We are essentially, with a few exceptions, using a 1910 model of medical education that was based on the idea that every doctor is going to be a solo practitioner in a small town. That's got to change. Work today is in teams. It involves technology. I've been told by students at medical centers that mine was the only course that ever asked them to envision what is healthcare, what are you going to be doing in 10 years, 20 years? They are taught, here's what we do today, here are the regulations, memorize everything. So, again, the 1990 legislation, if I were working on the Hill, I would dig back into it and say, how did we open up the internet? How did we open up telecommunications in 1990? What was the remarkable thing that happened in this place? It was enormously daring and very much underappreciated. It is the story of the century. Currently, through my work, I am holding a series of innovation dinners. I invite the most interesting people on planet Earth to sit around. I had one in this room just a couple of weeks ago with some members of Congress, the guy who propagated these around the world, guy who is general counsel for the company, for the Telemed company, and a couple of other innovators. And we just had a frank conversation about what does Congress need to do to get from the old world of the fortress and get healthcare over to the frontier. And I started that dinner right here with something I say at the beginning of each one of these dinners, which is, I almost never know the politics of the attendees. I looked, the representatives in attendance in this particular case, not always, were on the Republican side, and I said, just be known right now. The four innovators here, I have no idea whether they're Republicans or Democrats, liberals or conservatives. I don't know what they think. It doesn't matter. When we're talking about these things, it's like IT in 1990, where it's the lines are drawn differently, things, and what we end up with is, I like to claim, I'm about the only guy in healthcare policy around here who can have a really nice, pleasant evening with a room full of Democrats, Republicans, liberals, conservatives, and actually have a conversation that leads somewhere, leads to something productive. And that alone is reason for me to do what I'm doing rather than spending the rest of my life arguing about the ACA. So, I think you have a chance in what you're doing to make history. And I think it's barely appreciated, the opportunities that are out there if you shift the attention, if you bring these things to the attention of your bosses. I will state, I'm happy to help you. I hope this won't be the last time we talk. My email address is well known. I'm on Twitter all the time. Interact with me how you wish. But I would love to continue this conversation. I always ask at these dinners 4 questions. What are the new big things that are happening? And there's a whole lot of them that we can talk about in Q&A. There's technologies coming out in all sorts of ways that again, med school professors don't even know about yet. And I ask, what's stopping these things from happening? 3, what policy changes can loosen the logjam and get them flowing? And 4, what price are we as a society going to pay in terms of health and wealth if we don't unjam these things? And when you have that conversation, it's way more pleasant than the old insurance argument.